socioeconomic factors, but really at the top of the list is this idea of poverty. And when I talk about poverty in regards to rural communities, a lot of times it's really deep-seated generational poverty with our counties that are the furthest from our urban cores. Okay, so our most remote, most rural counties being the ones that have the highest poverty rates for our country, but then also our rural counties that have higher ethnic and minority populations. But overall, in general, in our country, rural counties have higher poverty rates than urban counties and lower household incomes in general. And what this leads to is less resources, okay, and in less individual resources, which makes sense, but it also means less societal resources. So things like whether your county has a hospital or whether it has a NICU or even whether you have a physician in your county, it has to do with the amount of resources you have. But what's unique to rural populations is this idea of distance that's really interwoven through all of that. And if you think about distance, those counties that are the furthest from the urban core, it really becomes much more difficult for them to overcome some of these barriers. And it leaves it so that all of the women in those counties have less less choices, less resources, but certainly the women who also have less individual resources have more difficulty overcoming those barriers that have to do with distance. And then finally, there's this idea of policy. And here, what I want to say is that most of the policy decisions in our country, things like how hospital systems are funded and how people get insurance, those decisions tend to be made in rooms where the majority of the people come from higher resourced metropolitan regions. And their life view is from the perspective of those regions. And despite good intentions, it's often hard for them to understand the other side of that and what it might be like to live over 100 miles from a hospital system. And so sometimes policy decisions are made that that inadvertently may disadvantage rural populations or may have kind of hidden down the road costs to those rural populations. But when you put all of this together, you end up with this problem of increased mortality rates. Okay, go to the next slide, please. What I want to do is talk about barriers and how this plays out for women in our rural counties who are pregnant and seeking delivery. And so I'm going to kind of do it as a case study. And our woman there on the left is a woman who lives in a rural county and is thinking about having a delivery. And one of the first barriers she may face, go ahead, Crystal, to the next slide, is that she may not have a hospital. And in the past 15 years, we've seen 170 rural hospitals close, which is 8.5% of our total number of rural hospitals. So it's not an insignificant percentage. It's almost 10% of our rural hospitals have closed. And they close for lots of reasons, mainly financial. But go ahead and show the next slide. But when they close, it ends up really impacting our communities. And what this slide shows is what's happened over the last 15 years with the blue hospitals, or the blue dots representing hospitals that closed in the first 5 years of that 15-year period, and the yellow dots representing hospitals that closed in the last 10 years. And whenever these hospitals close, that's a loss of inpatient services to that community, which I think is really easy to kind of jump to. But it's also usually the loss of an ER. Okay, and we know by doing case studies of these hospitals that on average, when that ER closes, that hospital closes, people need to travel an additional 60 miles on average to get to the next ER. So access becomes an issue, but then also behind those ERs sit all of the support services. So things like lab and x-ray and mammogram and whether people can get colonoscopies in their own communities. And these things really affect all of the preventative care services for that community and how the wellness of that population in general. And then also we see an exodus of healthcare professionals physicians and then also other healthcare professionals. And this starts a year before we see a hospital close, and continues for about 5 years. That exodus does, until that finally starts to stabilize with what is kind of the new normal for that community. And that's primary care physicians, it's specialists, it's PAs, it's PAs or APPs, nurse practitioners. And it's really all healthcare professionals that start to leave that community. And as you can imagine, these many of those professional jobs are higher paying jobs for that region, but then there are a lot of support jobs as well. And so the closure of this hospital is economically devastating because, as you know, they're often the major employers in a county as well. Okay. But let's say Our Lady finds a rural hospital. Okay, she has a hospital in her county. What's the next barrier she may face? And that is that despite having a baby being the most common reason people are admitted to hospitals in our nation, it may be that when she gets to that hospital that they do not have an OB unit. And this is a similar issue to what we've seen with the hospitals. Over the 15-year period, we've seen 230 OB units close. And the interesting thing is those are not the same as the 170 hospitals. Only 15 of those OB units closed because a hospital closed. The rest of those 230 closed long before a hospital closed, or even if a hospital remained open. And this also happens for lots of reasons. Go ahead to the next slide. And the main reason here is that it's expensive to operate an OB unit. Okay, that unit needs to be staffed 24/7, whether someone is delivering or not. In our rural communities, we have lower birth volumes, both because we have less, our population density is less, but also because we have seen a declining birth rate over time, over a couple of decades we have. And so because of that, each of those deliveries is more expensive because you have less deliveries to cover your overhead cost. At the same time that most of our deliveries in rural America are to women who have Medicaid insurance, 50 to 60% are to women with Medicaid. And although there are lots of ways that you can have those Medicaid births subsidized that get them closer to the rate of commercial payments, if you don't have those subsidies kind of stacked up in place, those Medicaid births pay about 50% of what a commercial birth pays. And so not only is your birth more expensive, but you're getting reimbursed less for it in these rural communities. And then add on this unique payment structure that actually disadvantages, disincentivizes critical access hospitals to provide OB care. And you can see how this balance tips to people deciding to close those OB units. But when those OB units close, what happens? In that first year already, we see more ER births. We see more out-of-hospital births, which continue, the out-of-hospital births continue even after the ER births dip down. And those out-of-hospital births are both home births, planned home births, and they are unplanned side-of-the-road births as people are trying to get other places. And then we also see a rise in preterm births, which they think is because of less prenatal care, less access to prenatal care. But this is a real issue for these rural hospitals because most of those preterm births in a rural community will happen within a hospital that does not have a NICU. Okay, all right, but let's say she solves that and there's an OB unit. The next thing that she may run into is there may not be a delivery provider. And here I'm going to talk mainly about physician providers because that's the literature that I know the most. But certainly this carries through for other health professionals as well, including APPs and other professionals. But that is 20% of our nation's population lives in rural communities. Only 10% of our nation's physicians practice in those same rural communities. And it creates this severe and disproportionate maldistribution of physicians in our country. And this is a long-standing pervasive problem. Happens for two reasons. One is that those, I saw you come in, stories of hope. We're going to get to the stories of hope, okay, because that's where Ray's going to come in. Okay, but I'm going to bring you down before then, so hang with me. One of the reasons that happens is because our rural students are students that are both economically and educationally disadvantaged. And so they, although they're as likely to graduate from high school, less likely to go to college, much less likely to graduate from college. And because of this, are less likely to get to the point where they apply to medical schools or get into medical schools. And those happen to be the students who are the most likely to also return to rural communities to practice one day. And then the other issue we have is that the vast majority of our medical training programs are located in high resource metropolitan regions. And so we're training a workforce to practice within those types of settings as well. And so when faced at the end of your training to decide to practice in a lower resourced or critical access hospital, sometimes the people graduating just are not comfortable with that because they haven't had training in that type of a setting where they may not have the specialty support or other support. And so we end up with a workforce that is both less interested because they have no life experience in rural communities, and less prepared or less comfortable to practice in those settings. And go to the next slide. And I'm going to kind of let you into a crystal ball, which is going to bring you down even more. And this is looking at matriculants to medical schools over the last 15 years, so that same period. And the blue line across the top shows an increase in our urban students in medical schools. And this is because we've added more schools, we've added more seats in our medical schools, knowing that we were heading towards this workforce shortage. So we have seen an increase, but at that same time, we've seen an absolute decrease in our rural students in those medical schools. And because of that absolute increase and decrease, we've seen this widening proportional rural students. And that graph started at about 8% of our medical students being from rural communities. And we're now at the point where only about 4% of our medical students are graduating who are have rural origin. And so we're actually on track for this to get worse. Okay, next slide. I'm going to switch to Michigan, and this is a study that we did that was partially funded by the Michigan Center for Rural Health, where we looked at Michigan's labor and delivery and prenatal services, and then we wanted to look at service lines also, so we looked at VBAC services within rural Michigan. Go ahead to the next slide. And to do this, we looked at 2015 Medicaid claim status. We looked at where we were actually billing for deliveries and billing for prenatal services in our state for rural Medicaid women. Go to the next slide. And what we simply did is, once we determined that there was billings happening, we put a pin in our map of where that hospital or that prenatal care provider was. And then we created, using GIS mapping, we created 30-mile radii around each of those pins. We used 30 miles because Medicaid feels that that's the reasonable distance to travel for prenatal care. Medicaid in Michigan does not have a specific designation for what's reasonable for OB care, but other states use that same primary care model for their OB and deliveries also. So we kept that 30-mile radius. Okay, go ahead, next slide. When we did that, this is what our map looked like. And these are hospitals that provided births to Medicaid women during 2015. And 29 of our rural hospitals were providing deliveries in that year, which is a little less than half of our rural hospitals. And you can see our green dots and our green circles, but what I really want you to look at is the grayish purple that's underneath those, because that grayish purple is our rural counties. And this is a map that illustrates our OB deserts. So the areas where women live, where they really need to travel what's considered an unreasonable distance to access services for maternity care. And we have a couple main areas in the Upper Peninsula, in both the east and west area of the Upper Peninsula, and then also the northeastern part of the Lower Peninsula of the state, which are our main deserts. Okay, next slide. This is that same map next to a prenatal map. And you can see here we do a little bit better job of of kind of blanketing our rural parts of our state with prenatal care. This is because providers will do satellite clinics. We have primary care providers. We have PAs, nurse practitioners, and midwives who are providing care in smaller clinics for prenatal care further away from those main hospital systems. But we still have some deserts, again, in the eastern and western UP, and then also in that northern part, northeastern lower peninsula. Next slide. And then finally, I'll just quickly show you our VBAC map, where we have a lot more work to do. Our VBAC map, we really have, we just grayed out the hospitals that didn't provide VBACs in 2015 or didn't provide that service for women who they were submitting Medicaid claims for. And as you can see, most of rural Michigan is a desert. And we really have areas that are prohibitive enough, distances to travel prohibitive enough that women are really left without the option of that choice after having a previous C-section for many areas of our state. Okay, last slide. But then I'm going to end on this slide because I want you to kind of have this slide in your mind as Ray goes through his talk, because I want you to think about those deserts in kind of ways that we can maybe improve some of this situation for rural Michigan. Okay, so Ray.
All right, good morning, and thank you, Crystal and Dr. Wendling for the introduction and leading up to my presentation. I was just wanting to share our story, our story of hope, and encourage everyone to consider similar efforts here at MidMichigan Medical Center in West Branch. Until 3 years ago, West Branch was a city-owned hospital until affiliated with MidMichigan Health back in 2018. But the hospital's been serving Ogama County and surrounding areas since 1927. We are at 88 licensed bed facility. However, we only staff 49 beds at this point. Roughly 500 employees, volunteers, providers. I think some of our highlights are our new ER that opened in 2019. We do have 3 surgical suites, not counting the C-section room. And then we have a very busy, successful wound treatment center as well. So next slide, please. In the maternity history here in West Branch, by the way, I had to point out, you've seen a lot of green and white from Dr. Wendley's presentation, and now the maize and blue fans can enjoy some of the Michigan slides here. But in July of 2010 is when West Branch had to discontinue its maternity program, primarily due to these 4 reasons. The provider recruitment and retention, as everybody knows, that's so difficult in the rural areas. Challenges with reimbursement and a changing payer mix. Andrea touched on some of those shifts into the Medicaid areas, which are very difficult from a payer standpoint. And this did lead to declines in the births and increased out-migration from the area to other hospitals, which is, from Andrea's presentation, a very common trend among rural community hospitals. In June of 2012 is when MidMichigan Health realized the need, started a need up in this area. So we did start rotating clinics with our Midland OB-GYN and pediatricians were coming up into West Branch in clinics, which definitely showed that there was a big need, which is an area, again, we wanted to help with that. And in 2018, West Branch did become a wholly owned subsidiary of MidMichigan Health, which really having that larger system and more depth and resources allowed us to start thinking about could we reinstate this needed service in this community. And in that agreement with the West Branch Medical Center to join our system, we did promise to reconsider maternity services. And so in November, about 7 months later after the affiliation, we did indeed develop a steering committee that involved the senior leadership and started talking about, can we make this happen, develop that timeline, how are we going to recruit, and put together an implementation plan. So if you look back, going back to the 2003, even, before West Branch had to close the program, we are averaging about 300 to 365 deliveries per year. Approximately 60% of those were from the West Branch Gladwin service area, but then another 30 to 40% originated from the secondary service area. So There's a pretty big geographic area that we were covering before. You can see in 2009 when talks started to talk about closing the program, and we were challenged with the with the physicians. You can see the drop off, and then we actually closed the program in 2010 there. So next slide. And this is just another geographical picture. What the discontinuation of services led to a very big population, pretty widespread, where patients had no longer access to delivery services. They were having to drive at least 45 to 60 minutes for that delivery of care. You can see the hospitals, Tawas, Alpena, Grayling, and Midland, but again, there's a pretty big desert there of no coverage. So next slide. So that steering committee got together, and we really started to talk about the why. Why would we want to do this? And obviously the community need and the gap was a big driver of this. Again, the 60-minute drive or longer for patients. The West Branch Board of Directors, the leadership team, as well as some key community leaders and organizations really got together and said, what can we do to make this happen? And it was a commitment to, access to care across all of our settings. We did look at, as many as the county health rankings in Michigan. Some of the rural areas struggle in that area. And Ogama County was 69 out of 83. And some of the key drivers to that were the increased maternal risk factors that were happening because of the lack of access to care for these moms, and also the increase in the inducements and also scheduled C-sections, which again, that can lead to lower quality and higher risk situations for the moms and the babies. So next slide. Also looking at the strategic opportunity, which again, that's also a critical part of the decision making. Maternity is a fundamental primary service that is expected in a community hospital. OB is looked at as a gateway service line that can engender years of family loyalty and also downstream revenue. And it also gives you that competitive increase in market share that can attract new patients and also retain current patients. So, an article that was pulled from the advisory board briefing, how do women choose their pregnancy care? This was a couple of years ago, but 74% of moms receive subsequent care from the health system that they delivered at. And then 34% of women who switched to a new system for pregnancy care returned for other care. And so women would really rather obviously deliver close to home. And so this was all part of that strategy when we decided to make this move. So strengths and opportunities. Number one, positive community perception and development of long-term loyalty, which we've definitely received a lot of great feedback. And I think the community here in West Branch and surrounding areas are just so happy that we've decided to attack this issue. Many of our patients, again, first contact with the hospital is through labor and delivery. It does set MidMichigan Medical Center West Branch apart from some of our competitors, being that we are a full service hospital, and again, indicates MidMichigan Health's a strong commitment to keep care close to home and keep that local. So the market also provides sufficient volume to support an OB-GYN program, looking at that 300 to 400 potential babies per year, and the fact there's a GYN program that comes with that makes this a program that is sufficient. The volume is there, especially if we can expand into the markets surrounding areas like Houghton Lake, Oscoda, Roscommon, Fairview, and even strengthen Gladwin. And it also, from a system strategy alignment, strengthens our strategy to expand and offer advanced neonatal and pediatric care by providing this access. So, okay, and of course the risks and challenges, which there were several, but I've identified the main ones. The recruitment of OB-GYN and pediatrics, very difficult, but we are committed to finding the right providers. Additional level of complexity with being that it's a new program, having not been active for the last 10 years. And so we're developing a new group of providers. And of course, until we get our full team in place, the locum coverage, very expensive, closing in around 75 grand a month to have these providers here until we get our team in place. Financial sustainability is obviously a concern for you CFOs that are listening, but it's definitely OB. I don't think there's too many OB programs that are profitable on a standalone basis. But if you bring in some of the other positives that come with the program, the GIN procedures and that, you can get close to a break even. And West Branch is fortunate enough that we will be receiving DISH payments of about $1 million per year. DISH payments are a program that helps reimburse hospitals for uncompensated care and programs with high Medicaid payer mixes. So that $1 million is definitely a help, was a help in our decision to decide to move forward. And also not only provider recruitment, but our nurses. There's challenges here in the rural areas with the nurses that have that expertise in OB, extensive training necessary for the new nurses. You know, these nurses, if they are interested and they don't have the experience, it's 6 months or more of training that we would need to get them from our other subsidiaries. And overall, about 30 positions were needed to start this program. And again, in the rural areas, it's not always easy to find those employees. So. But our commitment to our patients, again, quality care close to home. We want to partner with organizations as many as possible. The FQHC from Sterling, as well as the FQHC up in Roscommon, Houghton Lake areas, offering to help with recruitment and also those sustaining and building those relationships so that we can make this a successful program. And it does, you know, from our people standpoint, one of our commitments, it has definitely stirred the morale here in West Branch in our health system that we are offering this program, and so that's been a plus. And then over our from a business standpoint, it is strengthening the local hospital for building necessary foundation for continued growth. So that's our commitment. So next slide, please. Just real quickly on the assumptions. You know, we opened the OB unit on March 1st, so roughly 3 months ago. We've had 7 babies delivered in that time period. I was joking, it's 6-1 right now. The boys are up 6-1, but we plan on over the next 6 months, we've got about 40 moms in the chain to deliver here. So we are optimistic that in our first year, we will see close to 50 to 100 deliveries. And you can see it's from a volume standpoint, we do expect this to take 3 years to get up to full speed, if not longer. But the market share, going back to those, there is 500 deliveries in our market. So if we're able to capture 63% of those, and also in the secondary market, another 350. So again, the data is there. The volume is there, and we can make this successful and help a lot of moms and families that don't have the ability to transfer or drive those extra miles. You can see our payer mix down there in the lower right. About close to 60% of these patients are going to be Medicaid. And again, those are the patients that need the help and need the access to care. So we are committed to try to help with that. And that $1 million payments from DISH payments is going to be help stabilize the program. So. And then the FTEs that are needed, you can see required, we need 3 OB-GYNs. We need 3 pediatricians, and you can see we're hopeful. We have signed, fortunately, 2 pediatricians. One starts in August and one will start in January. And so you can see what we're projecting, though we do figure it's going to take the full 3 years to get our team in place. And so in the meantime, we are using qualified locums, and so we're very cautious and consider about who we use. We're using providers that have been in our system and know the program. So we're confident that we'll be able to offer that a high level quality of service during the time that we build up the team. One thing to keep in mind for those of you that are considering this, we were fortunate enough to look at some of the family residency programs, providers that want to work in rural areas that are interested in getting that, say, another year of fellowship to so that they can work as a pediatrician or even deliver an OB-GYN standpoint. So don't necessarily need to be an OB-GYN physician to fill one of these needs here. You could be you could recruit a family practice provider that's interested in getting that that extra fellowship so that they can join the team as either a pediatrician or an OB-GYN. And so one of our pediatricians exactly is what that happened out of our Midland residency program, which is a family practice. She is going to be having that fellowship training to be our to serve as a pediatrician, and also she serves as primary care. So that's also a plus in this community. So, and then overall at the bottom there, you can see we need 19 hospital FTEs, and then 6 in each of the OB-GYN offices and pediatrician offices to make up the full team. So. And just wanted to let you know, there were some capital costs to get this up in unit. Most of it was IT, even though we used the same unit that was used, the same area of the hospital that was used 10 years ago. There were about $2.4 million in costs that were needed to bring in the electronic medical record and the equipment and all the updated, especially some of the costs were in the C-section suite to make that up to date. So, and the next slide, I just wanted to mention, Andrea and I have talked a lot of the challenges, but there are also a lot of benefits to having this program. What we've noticed in our recruitment here in West Branch is, since we've announced the plans to open the OB program, we've seen some much more success in the primary care recruitment. We've recruited a breast surgeon, a new orthopedic surgeon, 2 pain management providers, and a neurosurgeon part-time. And as we talk to these candidates, it's definitely, you can tell when they hear our plans and our commitment to this OB program in the community, it definitely makes a difference in how they see the opportunity. We do strongly feel that many of these providers, which over the last 6 months, we've actually recruited 11 providers, and we feel a lot of that is the fact that we started OB did play into their decision making. Again, they see that commitment. They're excited that we're doing what we can to serve this community, and that makes a difference to them. So, and it does help with other staff, clinical, administrative, even. It just adds a lot of excitement to know that we are having an OB program here. And another big point, it helps with medical student rotations, and both with MSU and CMU. Having an OB program allows, and a pediatric program makes it more meaningful and more likely to have students rotate. And as Andrea pointed out, that can lead to future recruitment and have them back in our areas as physicians as they complete their journey to be a doctor. And also, we're hoping to get some resident rotations up here now as well to help with the program. So there's a lot of advantages outside of the challenges of an OB program that we feel are going to definitely make this successful for us. So I did add a couple pictures on the next slide just to show you guys. Again, this opened March 1st. The top left is a picture of the main hallway in the maternity unit. You can see a patient room to the top right, and then our C-section room to the lower left. And then the team that got us going, these are the nurses that were part of opening day here. So pretty exciting in West Branch. And so hopefully this presentation gave you some ideas and about our journey to get where we are. And again, we love to give you an update in about a year from now, because I'm pretty confident we're going to be successful with this program. Questions?
All right. Well, thank you so much, Dr. Wendling and Ray. I think it was a really informative and engaging presentation that highlighted the challenges that we still have to overcome, but having a facility and an organization step up to meeting those challenges. So wonderful. So I am going to stop sharing, and we do have time to open it up for question and answers at this time. So I have one that while we're waiting for some questions to come through the chat, Dr. Wendling, you're such an expert in this space, and I loved how you outlined the kind of the issues that affect maternal health care policy, reimbursement, poverty. So this is kind of a big one, but if you had a wish to waste that would assist in closing the health equity gap for moms in rural areas, what would that be?
Oh man. Boy, that's a tough one because I only get one, right? And I probably can't say more wishes. So I think, it's hard. Like, you think about these ideas. This is huge, right? To build a labor and delivery suite is like, huge and inspiring and exciting, you know, or to reopen. And I think that we have seen so much contraction, you know, that it's really exciting for a rural community to see this expansion, you know, like that brings hope. And I guess my wish would actually be that the people who care about the issue would actually kind of get together
Okay.
and send like the money that we need in order to solve it, right? And some of that probably would come through the Medicaid system, since that is the majority of payers, but that money would funnel into these different places, you know, like you know, building new suites, but then also, you know, help with the workforce issues and really get deliberate about that and how we want to change that for our state. And think about like even the prenatal care. Some of those things are easier to solve because, you know, if you know that these areas, that women in these areas are at risk, it's like, you know, start to think about how you're going to distribute services to help. And I think there was a presentation earlier today where I saw like the UP counties kind of whited out because they didn't have data, right, for those
Oh,
counties.
yeah.
And I'm like, okay, so that's probably where the problem is. Like, don't stop there. Like, really kind of dig in and figure it out. But you need the people who have the ability to make the decisions to care enough to want to solve that. So,
Yeah. Well, thank you. And then Ray, you know, this is such an important issue, and to have an organization kind of step up, I think there's going to be a lot of learnings in the future for other, hopefully, organizations that might be looking at this. So, you know, would you be willing, if the center facilitated some sort of peer learning or kind of Q&A with other facilities that might be interested in opening this service line? Would that be something you would be open to?
Yeah, absolutely. I'm sure many of my team members would love to share their experience. We're still learning this, but I think we're definitely should be able to help in some fashion with others that are considering this. We'd certainly be glad to share our experience.
Well, thank you. Any closing comments from our two speakers?
thank
All
you
right.
for
No,
giving us the
thanks for
opportunity to present.
yeah,
Well,
thank
thank
you.
you guys so much. We really appreciate it. It was an excellent presentation and obviously a very timely and important topic. So thank you so much. That does conclude our content for the 2021 Michigan Rural Health Conference. We do sincerely appreciate all the wonderful sessions by our speakers over the last 3 days, and the attendance and engagement from participants. As noted before, we also sincerely appreciate the support from our partners. So if you have yet to, please take the chance to visit our conference partners page located on the Michigan Center for Rural Health website. You can learn more about them and how to connect with them. They do support our work in rural Michigan throughout the year, and then they also support this event. So thank you. So once again, thank you for attending. Please remember to complete the evaluations, and we look forward to seeing you in person in Mount Pleasant in 2022. So please save the date for that conference. That will be April 28th through the 29th of 2022. We will be celebrating in person and learning from content experts on rural health in Michigan. So thank you all and enjoy the rest of your Thursday. Have a wonderful day.